Assalamu alaikum, my dear final year students. How are you? It's very unfortunate that we are meeting again this year in COVID-19 environment, but we should all pray for the good times to come. Inshallah, they will come. So we start your final year lectures with the most common, almost common disease among others, cholelithiasis and cholecystitis. As the name indicates, it's inflammation of the gallbladder and stones in the gallbladders. Objectives of today's lectures are that at the end of this lecture, you should be able to know to recognize clinical features of cholecystitis and cholelithiasis, and you should be able to differentiate between causes of pain and right hypochondrial pain, or a differential diagnosis of cholelithiasis and cholecystitis. And you should be able to investigate a patient with pain abdomen, and especially pain right upper abdomen. And furthermore, you should be able to interpret different investigation when a person comes to you with his or her investigation, and then you can comment over those investigation that what may be the problem. Now, how patient present to you with pain right hypochondrium? If we talk about of the gallstone. So gallstone may be asymptomatic, and they're sometimes detected incidentally. Incidentally mean that you do ultrasound for some other purpose and you find some stones. Typically, pains arise in right hypochondrium or in the epigastrium, and it may or may not radiate to the back, to the chest. Nature of the pain is colic type, and it's more often dull and constant. And sometimes there is severe pain which is called biliary colic, and that pain is severe, fluctuating, and fluctuating means that it disappears, it increases and decreases in size and its severity, and is associated with nausea and vomiting. This pain may last for a few minutes or even for a few hours. And mostly this pain starts at night, but even at the day's time, the pain may occur with the same typical features. When you inquire from the patient, other features may be dyspepsia, flatulence, food intolerance, and fever, and jaundice may be present. Now, remember, whenever you come across a patient with who is complaining something of abdomen, so it means that you are dealing with gastrointestinal tract. So you will ask all those questions which are related to the GIT, like nausea, vomiting, dyspepsia, flatulence. Even you will ask about the bowel habits, color of the stool, because this may be related to the pain which the patient is pointing. It may be pain in the epigastrium, but it may be related to gut, any part of the gut. It may be transverse colon, it may be stomach. So you will have to inquire all questions about that system. And not only that system, like a patient complaining of pain in the upper abdomen. So this pain may be due to basal pneumonia, some problem in the lungs. So you will also ask from the patient about chest complaints like breathlessness or cough. Now, what complication this pain can give rise to? This pain of due to cholecystitis or cholelithiasis, which I have already discussed, that typically it arises in the right hypochondrium. Now, it may give rise to biliary colic, or I can say that if there are stones there, what other scenario can arise from that stone? Patient may present with acute cholecystitis, as we have discussed. Patient may have chronic cholecystitis. Chronic cholecystitis means that pain of a mild severity as compared to acute, but recurrent pain. Again and again, patient pain subsides, inflammation subsides, but again it recurs. Empyema of the gallbladder is another complication. Empyema means pus in the gallbladder. Now, if a patient is having empyema of the gallbladder, so again, the same pain in the right hypochondrium, but it will be very severe pain and there will be high grade fever. If it is acute cholecystitis, the fever will be mild, but in empyema of the gallbladder, there is fluctuating high grade fever. Mucocele patient will complain of some. What is mucocele? Mucocele is when there is stone stuck at the gallbladder neck, and there is stoppage to the passage of cystic duct content to the outside. So what happens? Whatever bile is there, it is the water is absorbed, but the mucosa of the gallbladder secretes mucus, and that then leads to mucocele, fill up of the mucus of gallbladder. And if this action has not been taken by the surgeon, what happened? Mucocele converted to empyema of the gallbladder, and empyema of the gallbladder may rupture, may perforate into the surrounding structure, and may give rise to peritonitis. Similarly, if again this perforation, if it perforates, there will be, if the pain will be more generalized than in the acute cholecystitis or chronic cholecystitis. The whole abdomen will be maybe painful, and on examination it may be tender. Then biliary obstruction, if some small stone slips from the cystic duct into the common bile duct, I will show you anatomy later on, it may give rise to biliary obstruction. Now, whenever there is a biliary obstruction, what do you expect? You will expect jaundice. The patient may be jaundice. Acute cholangitis, if there is obstruction, if the small stone is there, so whenever there is blockage, there is backflow develops, and that give rise to uh, backflow or fluid into the in the biliary channels. I mean to say that there will be, when there is a blockage of the CBD, so contents coming from the from the liver cannot come down, so there will be stasis of the bile in the biliary channels, and that condition will may give rise to infection, because whenever there is stasis, there are chances of infection, so it will lead to acute cholangitis. And acute pancreatitis, why it will occur, I will show you later in a picture, that how gallstone can give rise to acute pancreatitis. And intestinal obstruction can occur with the gallstone. How it occurs, I will show you later. So I hope now you can understand that what are maybe the features of what may be the sequelae of acute cholecystitis or cholelithiasis. Pain right, I will repeat again, pain right hypochondrium or epigastrium, it may be constant or it may be dull, it may fluctuate if there is biliary colic as well, and fever may or may not be present. If there is no infection, there will be no fever, but if it is infection, then depending upon severity of infection, there will be mild fever if it is acute cholecystitis, or if it converted to the empyema of the gallbladder or perforation, so then there will be severe high-grade fever. Now, how you will get this question in your exam? The question will be, a 40-year female presented with pain, right hypochondrium, and there is mild fever, and pain mostly occur at night, but sometimes it occurs in the daytime, and she is having a low-grade fever. Now, what is your most probable diagnosis? What are your differential diagnosis, and how you will investigate? This is a typical question. So I hope by passing through this symptom features of the cholecystitis and cholelithiasis, you will, I hope you can pick the diagnosis. Now, after taking history, then you proceed to examination. So when you attempt that question, as I just mentioned, so when you can attempt, they will give you some questions, like they may have given you that there is a pain and there is a fever. So you will write that I will ask about other features like flatulence, dyspepsia, nausea, vomiting, and then on examination I will look for general physical examination. What you look on general physical examination? You look for the appearance of the patient. If there is inflammation, the patient appearance tells you that patient is just unwell. You can, anybody can say that this person is unwell and this person is well. So this is the first thing that you will guess that inflammation is present or not, because only gallstone will not cause uh, appearance disturbance in the appearance of a person. Now, if there is inflammation, the patient pulse will be tachycardic, and there will be fever may be present on when you check temperature with the thermometer. And then you proceed to systemic examination. As this symptomatology belongs to the GI system, so we will proceed with the gastrointestinal tract examination. And the first thing, you expose the abdomen How you expose? You expose from the nipple up to the mid thigh, because so that you do not miss any other associated phenomena or any other disease. So look for inspection. Inspect that whether abdomen is moving with normally with the respiration, or there is any um, because if there is some inflammation at some spot, so patient try to avoid, try to limit the inspiration and expiration, so that there is no pain or disturbance at that area. And then you proceed to palpate. When you palpate, now these things we will discuss when we come to the clinical, like when you come to the patient's bedside at the in the OPD, so we can you can appreciate how to palpate. But when you palpate, you should warm your hands, and you should gently touch the patient abdomen and look for where is tenderness. Your eyes should be on the patient face, so that if there is discomfort or pain, you should not press. Uh, Otherwise, patient will have more pain. Now, look for tenderness. If there is some tenderness, then the next step is Murphy's sign. What is Murphy's sign? Murphy's sign is that whenever there is inflammation at that spot, patient limits movements. Like when we check for appendicitis, when we press, when we gently palpate and we put some pressure over that area. So due to inflammation, appending the peritoneum try to avoid. So there is a gardening of the muscle become tight, so that our hand does not reach to the inflamed area. Similarly, when a patient having inflamed gallbladder, when there is cholecystitis, so when you put your hand on the subcostal region and you slowly palpate, go deeply and ask the patient to take a deep breath. So when the patient take a deep breath, at, at that time you are pressing from the down and the upside lungs and coming down. So what happens, the gallbladder may touch your hand and that's inflamed. So what happens at that area, at that time patient catch holds of his or her breath, and that's so then we say that Murphy sign is positive. This is the catching, holding, is the holding of the inspiration when you palpate, and there is there is patient is feeling some pain, so patient will stop inspiration, and that's then we say that Murphy sign is positive. And the Murphy sign is positive in acute case. Sometimes you can feel a mass if it patient is going to develop empyema of the gallbladder, because it is natural phenomena in our body. Whenever there is inflammation surrounding structures, and especially omentum come at that area to wall off the infection, and that then leads to a mass like vague mass like feeling will be appreciable at that area. Another important thing, the Corvisor sign or Corvisor law. When you palpate and you palpate, there is gallbladder is palpable. How you feel that gallbladder will have a conical shape, or the fundus of the gallbladder may be palpable, and it is non-tender. When it is non-tender and palpable, so most likely it's not due to stone. It is due to something in the at the lower end of the biliary channel, most probably some tumor. Because whenever there is stone, so it will leads to inflammation, cholecystitis, and then that leads to contraction of the gallbladder. So gallbladder becomes smaller, shrunken and smaller. So it's unlikely that patient have uh, enlarged gallbladder. Whenever you palpate a gallbladder, so think of some tumor at lower end. Now, as I told you before, that a patient complaining of pain, right, hypochondrium. So, what can be the possibilities? This may be the question in your exam. That what are different differential diagnoses? So, whenever you are asked about differential diagnosis of any disease, so if you don't know, just imagine what anatomical structure may be there at that area. Suppose, forget about right side. If there is a complaining, you are asked about the differential diagnosis of the left hypochondrium. So what structure are there? There is stomach, there is spleen, there is splenic flexure of the colon, there is left kidney. So you can give them pathological names. Like splenic abscess can give you pain at that area, splenic rupture can give rise to pain at that area. Similarly, on right side, uh, differential diagnosis mean that what other possibilities. So we are discussing now cholecystitis. So the purpose will be the differential diagnosis of acute cholecystitis. So the most common may be hepatic abscess, but hepatic abscess patient may have similarly pain, but the fever will be high grade and fluctuating. So if there is a high grade fever, it means it may be hepatic abscess, it may be empyema of the gallbladder. Similarly, severe pain. Now, these all are conditions which will initially present with pain, right hypochondrium. Even the appendix typically is in the right iliac fossa, but a high-lying appendix. Sometimes appendix may be lying in the because it arises from the cecal, and cecal descend from the embryologically descend from the right hypochondrial area from that region. So if that is stuck due to some congenital anomalies, so patient will have appendix pain of appendix at that area. Similarly, perforated peptic ulcer, patient will again have pain epigastrium or right hypochondrium and pain of acute pancreatitis. Now there is some difference in these pain may be there then. Like appendicitis pain will be mostly shifts to the right iliac fossa, and there is nausea, vomiting is there. For peptic ulcer, usually there is history of peptic ulcer disease, and there may be pain of sudden onset, very sudden onset, because whenever there is perforation, so the content of the gut when touch the peritoneum, so even patient remembers time of that incident when the pain has been started. And acute pancreatitis, inflammation of the pancreas, very severe pain, but that pain radiates to the back, and it is relieved when the patient sits or lean forward. And when the patient lies on the bed, so as the pancreas is retroperitoneal structure, so it's due to pressure of the rest of the organs of the abdomen, then pain increases when the patient lies down. Hepatic abscess, I already told you. And other possibilities are acute pyelonephritis, inflammation of the kidney. Epigastric pain may be very tricky. Sometimes patients have epigastric pain. Even I can quote that some doctors were having epigastric pain and they thought that they're having gastritis. They took some omeprazole-like drugs and they were actually died because they were having myocardial infarction. So any patient, especially above age of 40 with epigastric pain, before doing ultrasound, I will suggest go for ECG. If ECG is normal, so no problem, you can then go ahead with the ultrasound, because patient will not die from the acute cholecystitis, but if you miss ECG, patient will die from the cardiac disease. So keep it in mind. And pneumonia or right lobe, because the right hypochondrium is the junction, is the border of the abdomen and the chest. So consider consider pneumonia, lobar right lower lobar pneumonia. Now, so far I hope now you can understand that what I just to summarize, that a patient complaining of pain, right hypochondrium, what can be the possibilities, and what are the different features of different pains, and I hope you can now differentiate between the different pains of the right hypochondrium. Now, then we proceed. The next step is investigation. I always divide investigation and make it a habit to divide investigation of any disease, any ailment into three categories: to confirm diagnosis, to know the extent of disease, and to know whether if it is surgical disease, then we go for whether patient is fit for anesthesia or not. What you can start in the other way, that I will do CBC, urinary, urea, sugar, but to me it is logical that first thing is whether patient is having some problems to proceed with or not. Like in this example, a patient complaining of pain, right hypochondrium. So to confirm that, I will go first for ultrasound. Similarly, if a patient present with a lump, a small lump or whatever lump, so the first thing I will, if I'm asked that how you will confirm, so in addition to ultrasound, I will say that I will do aspiration biopsy, needle aspiration biopsy. So in this case, to confirm diagnosis, ultrasound will mostly help us, will confirm the diagnosis of this disease. And then there are other, if it is not confirming, I will discussing later on that what other investigation we can do to confirm our diagnosis. Then extent of disease, that how much severe this disease is. Like for example, if a patient we did ultrasound, it shows gallstone, so it means that there is cholelithiasis. Now, how what I mean to say extent of disease in this case, that whether how much that disease is severe, and how you will know, because the gallbladder belong to the biliary system. Biliary system means hepatobiliary system. So I would like to know the status of the liver, because if the liver is diseased, so morbidity and mortality increases. So I want to know that what is extent of disease. So for that purpose, what test I will do? I should do LFTs and serum amylase to know status of pancreas and liver. Now, fitness for anesthesia, remember that any patient, the fitness of anesthesia are almost same for all patients. So you will, the first thing, the hemoglobin level. Now, in extent of disease, when you do the CBC will also give you the hemoglobin and the neutrophil count. Now, neutrophil count, if it is raised, it shows inflammation. Again, it shows us extent of that disease. And for fitness, we need hemoglobin level. It should not be less than 10 for optimal anesthesia recovery results. Second thing, we should be able to know the optimal renal functions, urea creatinine, and similarly sugar level, because these are metabolic conditions. Uh, we should take care of this, because we are not treating only gallbladder disease. We are not treating only removing gallstones. We are treating a patient as a whole. So when you treat patient as a whole, you look for everything. And then I already discussed ECG is very important in patient, every patient, and especially patient with age over 40 years, because if there is some cardiac problem, that should be addressed first before going to the gallbladder. So these were the plan of investigation. Now, before you can understand and you can interpret the ultrasound, you should know anatomy of the biliary channel, that what's how it looks. So there is gallbladder, and gallbladder may contain stone or not. There you can see this is cystic duct. Gallbladder is around 7 to 12 centimeter. Its capacity is around 30 ml of, and this cystic duct is of variable size, but it may be up to up, zero point 0.5 centimeter, sometimes very short. We call it short neck, directly attached here. So it may be zero point 0.5 from zero point 0.5 centimeter up to 3 centimeter. Then the right and left hepatic duct, they join to form, right and left hepatic join to form common hepatic duct. And common hepatic duct is usually around 2.5 centimeter. And when common hepatic duct joins the cystic duct, it forms the common bile duct. And this common bile duct is around of 7.5 centimeter. Now you can see just near the entry into second part of the duodenum, here it is second part of duodenum, it joins the pancreatic duct, and then it opens into the ampulla of Vater in the second part of the duodenum. Now we have said that these stones may give rise to pancreatitis. How they can give rise to pancreatitis? If stones, small stones can slip here, and if it is stuck here, it will give rise to back pressure in the pancreas, and patient may develop pancreatitis, acute pancreatitis. If similar stone is stuck here, so what will happen? Patient will have jaundice, and after jaundice, there is back pressure over it, and patient, there are many channels of small biliary channel, then it will leads to cholangitis. So therefore, it's very important to know the anatomy of the this biliary channel, so that you know that how to interpret the result of ultrasound. Similarly, thickness, if the report is that there is the lumen, the wall of the gallbladder is thick, what does it mean? How do you interpret? It's very important how to interpret. So you interpret that there is acute cholecystitis. If it is, but if the wall is normal, it means that it is just cholelithiasis. So normal wall with stone, cholelithiasis. Thickness increased, so cholelithiasis with acute cholecystitis. I hope anatomy is clear to you. And this is just furthermore anatomical variations, anatomical detail. You can see this this is the right hepatic artery, and this right hepatic artery give rise to cystic artery. And this area you can see, this is called Callet triangle. What is Callet triangle? It is on the medial side bounded by the lower end of the liver. On the lateral side, it is bounded by the cystic duct and some part of the gallbladder, and on the medial side, sorry, this is the medial, yes, medial sides, and on this side it is bounded by the common hepatic duct. This is called Callet triangle. three boundaries: lower edge of the liver, cystic duct, and common hepatic duct. Now, what's the importance of this triangle? This triangle contains two structures. One is this cystic artery, and other is lymph node of Lund, which is present here, which drains the gallbladder. And you can see here this passing behind the first part of the duodenum, this common bile duct, and here it joins this in this C-shaped area. The pancreas is lying, and from the pancreas, some small duct is coming, and it's then open in the second part of the duodenum. Now, in our body, two structures are very notorious for anomaly can occur anywhere, but two structures are very notorious uh, for abnormalities. One is biliary channels, and second is sorry, the short saphenous vein. Short saphenous vein may open in the popliteal artery above the knee joint, at the knee level of the knee joint, or below the knee joint. So that needs angiography, etc., so that you know the exact point where the short saphenous veins enter into the popliteal vein when you are doing surgeries for the varicose vein. That's a different topic, but I just want to tell you that anomalies are more common in that area and in the biliary channel. You can see here, sometimes patient will have pain right hypochondrium, and when you do ultrasound, there may be two gallbladders with one cystic duct. There may be two gallbladders with two different cystic ducts. There may be bifid gallbladders, and there may be trifid gallbladders as well. And there may be gallbladder with a diverticulum. And you can see even sometimes it's instead of opening into the common hepatic duct, it opens the cystic duct open into the right hepatic duct. So it's very uh, like tricky, and sometimes it gives rise to complication. Arise why? Because when you think that the anatomy is normal and you cut it, and then there is biliary leak and problem arise. So it's very important to understand the anomalies of the biliary system. I will just discuss the triangle. You can see this triangle, and this is cystic artery. This is a hump of the right hepatic artery. It's very important to know when you cut, you should cut close to the gallbladder, because if you go away, you may cut the hepatic artery, and it may be there may be very enormous bleeding may start. Other thing I have just told you that lymph nodes are also lying at that area. So two structures, cystic artery and lymph node affluent. Now, 90% of the water, the biles contain 90% of the water, and the rest are the bile salts and bilirubin. Liver excretes bile at rate of 40 ml per hour, so it makes around 1000 ml per hour per 24 hours is draining from the liver. But the good thing is that 95% of the bile salts and these fluids are reabsorbed in the terminal ileum again, and there is this is called enterohepatic circulation. So the body water and body salts remain normal. Now, gallbladder function is just a reservoir for bile, and it's concentrate the bile 5-10 times, and it's secrete mucus approximately 20 ml per day. So when you, although it concentrates, but if it is removed, there is no problem, because you know then through the entire hepatic circulation, 95% is reabsorbed in the terminal ileum, and uh, no physiological problem arise. One investigation we have discussed, the ultrasound. This is the main investigation to confirm diagnosis. Now, this is ultrasound is not required for to diagnose the gallstone. It's just an academic or just an interesting picture that 10% cases they are radio opaque. Otherwise, they are radiolucent. They cannot be visible on the X-ray. But you can see 10% stones are having some more calcium content, so they are appearing in the X-ray. As I told you earlier, that what you see in the ultrasound, you look for stones, thickness of the gallbladder wall, and biliary channel dilatation. Now, normal size, if I go back to biliary, So the size of this common bile duct, when you read in ultrasound and you interpret, you look for size of the common bile CBD, common bile duct. It should not. Usually it's 3 to 4 mm, but it should not be more than 1 centimeter. If it is more than 1 centimeter, it means that there may be some stone or structure at that area. So you should then go for other investigation. So ultrasound tells us stones, thickness of the gallbladder wall, biliary channel dilatation, and liver pathology. If there is some abscess or cirrhosis, so we can appreciate through ultrasound. Now, sometimes there is some suspicion in ultrasound, or for example, we have done some surgery and patient have developed jaundice, and then we are suspicious that has what has been gone wrong. So then we go for other investigation, that is MRCP. Sorry, MRCP is magnetic resonance cholangiopancreatography. It is a non-invasive imaging modality, but it is just diagnostic. It's not therapeutic. There are two which we'll discuss later on. Another is ERCP, and this is MRCP. So MRCP is diagnostic. It shows us anatomy of the biliary channels. If there is some obstruction, is there a structure, or if we have ligated by mistake the during surgeries, if we have ligated common bile duct, so it will show us that there is some obstruction at that area. Now, you see, this is MRCP, and you can see these are small filling defect. These are filling defect mean that the dye has filled the rest of the area, but there is this defect remain. So what it is? It is CBD, and it's most probably these are stones. So you can see stones here, and there is, it may be stone. So this is MRCP. So it's just a diagnostic. It gives you anatomy of biliary channel, and if there is some dilatation of the CBD, if there are some stone or some narrowing, so it will show us. And then if we see there's some stones are here, then we proceed to ERCP. Now ERCP is diagnostic as well as therapeutic. Now why not directly go for ERCP? Now ERCP is invasive procedure. Invasive means that it can damage something. So we should have confirmatory evidence that stone is there, because sometimes an ultrasound will tell you that stone are in the CBD, but when you go for ERCP is an invasive procedure. So, and there are no stones, so what will happen? There will be no stone, and you will damage you will create some other problem. So for that purpose, it is a patient goes through this tedious list of investigation, but for safety purposes, for the patient safety, it's better to go first for MRCP and then for the ERCP. Now it is diagnostic and as well as therapeutic, mean that it can diagnose that stones are there, and it can remove those stones, it can do something. How we put, like if you have seen endoscopy, there is a endoscope, a flexible tube which is passed through the oral cavity. It goes into the esophagus, then into stomach, and then into the second part of the duodenum, and then there is a lateral viewing channel which enters into the ampulla of Vater, and then dye is pushed in, and it gives you, and you take image, and it gives you image. Now this is endoscope. This is passed into the oral cavity, and through this the camera, the gastroenterologist looks for the pathology. Now this is that endoscope you just seen, and this is the part of the second part of duodenum. Dye has been injected, and you can see the CBD. This is CBD is illuminated, delineated. Again, you can see this is the very beautiful pancreatic duct going to into the pancreas, and this is ampulla of Vater. Dye has been pushed, and are showing you the common bile duct. Then this cystic duct. This is gallbladder. This is common hepatic duct, and the right left hepatic duct. And then there are small biliary channels, beautiful umbrella. Now, what causes gallstone formation? It's not yet very clearly understood, but a few things are understood, that age, more than 40 years age, females are more prone to this due to hormonal fluctuation throughout their reproductive life. Genetical predisposition is there. Some families, they are predisposed to develop gallstone. In obesity, there is a lot of cholesterol in the body, and if you take a lot of cholesterol and very high caloric diet and red meat all the time, red and white meat all the time, so that there are chances of stone formation. If gallbladder function is impaired, like gallbladder function is to reabsorb the bile salts and water, but if there is some problem, some there is mechanism, some inflammation or whatever, and it cannot absorb, so there is stasis and then stone formation. Similarly, infection, if there is some infection occurs, so what happen in infection? Now, the bilirubin is remaining in conjugated form, it is soluble. But if infection occurs, infection leads to breaking down of conjugated bilirubin, and then when it is unconjugated, it precipitates and creates enucleation and nidus for stone formation. Enterohepatic circulation, like if there is some problem, ileal resections, suppose the patient has some tumor or some trauma, and we have removed a lot of ileum. So, 95% of it reabsorbed into the ileum and goes into the liver, and so it increases fluidity of the bile salts. But when there's enterohepatic circulation is disturbed, so there will be less fluid there and there. So the solutes will precipitate and will lead to stone formation. So this was all about so far. If I summarize for you that we have discussed today the clinical presentation and examination findings of cholelithiasis and cholecystitis, and then we have discussed the different differential diagnosis of that disease, and then how you proceed to investigation. Apart from this investigation, I told you that you do ultrasound, MRCP, and ERCP. You will also do LFT is very important. Serum amylase is also important, and CBC is you discussed in the under the category of anesthesia fitness. So I hope you have learned something today. You can give me feedback. You can ask me question. What has been went good in this lecture? What was wrong in this lecture? And see you next time, inshallah. Thank you. Allah Hafiz.